Shrinivas. Shrinivas is a brilliant, surgeon, vitreous surgeon from Karnataka, and I am very fond of his surgeries, and he shows wonderful videos and has won Resbakla Award not once, not twice, not thrice, so many times? 6 times, I think. 7 times. So therefore, you should watch his surgeries with a lot of awe. Yes, Srinivas.
Thank you, sir. Thank you very much for that kind introduction. Thank AIOS for this wonderful opportunity. So here I'll be quickly speaking, upon the sutureless SFIOLs. How do we go about it? So now let me quickly go into a few of the videos. So this is how, if you have a decentered IOL with the CTR, so you can just remove the CTR, and then since it was a 3-piece lens, you can just fix the same lens. So I'll be showing different techniques of how we can fix the same lens. So here I just try to dial it. I made a flap, made a Hoffman pocket, and then hold it at the edge or the tip of that haptic so that it doesn't bend, and then make a small tunnel using a 26 gauge or 27 gauge needles, and then just try to pass it to the Sharot's tunnel. So this is a pretty simple technique, not much of disturbance, and this whole thing was just over within 30 minutes. So this is the another case where it was a aphakia, and you can see the superior part of the area there was a bleb. So here what I am doing is a modified Sergio Canabrava technique using a 6-O-Prolene. So I have already threaded that 6-O-Prolene into that 30 gauge needle. It's a 30 gauge thin bore needle. It's not a regular needle. A regular 30 gauge needle, this Prolene doesn't go inside. So I am now bringing it out through the tunnel, and then similarly on the other side, you just pass that 6-O-Prolene and then bring it out. So once we bring out this 6-O-Prolene, just pass it through the eyelet of the SFIOL, as you're seeing here, and then slowly flange it. So once we flange it, make sure you pull it and check it. Otherwise, sometimes if it's too small a bulb, after putting into the vitreous cavity, it might give away. So after flanging on both the sides, just introduce it, stretch it on both the ends, cut it, and then flange it. So this is also a very interesting and very simple technique of how we can handle these kind of aphakics. Now this is another interesting case where we call it as a dangling SFIOL. You can see one haptic of the SFIOL is dangling. Now instead of removing the whole SFIOL and putting it back, what we can do is we can repair the same dangling haptic can be bought. So now with the railroading technique, I'm just trying to pass that. This is a 9-O-Prolene. Now catch the end of that 9-O-Prolene, and bimanually you can just thread it inside in the vitreous cavity and bring it out, make another entry, and then use that ILM forceps and just bring out the one which you have already threaded into the eyelet, and then just tie it under the flap. So now you can see this is stable on both the sides, and we did not have to explant this IOL. Now this is another case of again the subluxated SFIOL, where this is another case where we saw it dangling. Now these are the cases which are coming up, which were earlier operated 15 years back for the sutureless for the sutured SFIOL. Here the one which I showed before was using a 9-O-Prolene, but here we are using a 6-O-Prolene. So again, as you can see here, make a small entry into the AC, then pass that 6-O-Prolene through the 2 mm long needle track made. You can see here I am just passing it through the needle track made, or you can thread it before passing it into the pars plana route, either of the one, whichever best suits you. Here what I am doing is trying to thread it into the lumen of the 26 gauge and externalize it. And once we externalize it, now take this other end, just flange it first because it should not slip down. Then now use this another end. Now once we put it into the vitreous cavity, make sure that when we are dialing into the vitreous cavity, it should be upside down, not downside up. Now you can see here, hold the eyelet carefully and then just thread it inside in the vitreous cavity and then bring it out. So once this end is bought out, now you can just flange it and make sure that the bulb is sufficient inside, sufficient on a bigger size. And then just pull that, the other end, it gets fixed. So it's a nice centration what you can see here. Just cut this end using a heat cautery, Bowie heat cautery. You can just form a small bulb and make sure that the bulb is made in such a way that it's a rounded shape and it goes back into the track of the scleral track what we have made. Or in case if it is little larger, you can still tuck it under the conjunctiva, but I would suggest to make a flap in those cases. Now indented examination was done in this case, and so this is the post-op of that patient doing really well, post-op day 1. Now coming to the last one, this is the anaerobic SFIOL. In anaerobic SFIOL, again similar technique of these modified technique of Sergio Canabrava, it can be used. So here I am just bringing out both the ends, and this, the what modification is being done here, it's under the flap. So even if there is irregularity of the bulb, using the Bowie cautery, it will not matter much because it is covered under the flap. So this is the last video I just operated a few weeks back. This was again a subluxated IOL, 3-piece IOL. So instead of removing, what I thought was I'll just first complete the vitrectomy and use a 27 gauge entry here. Smaller the gauge entry is always better, lesser the chances of slippage. See here I have just marked it. Now you can see here I am using a 27 gauge trocar cannula, and I make a small Z entry there and then catch hold of that haptic, bring it, externalize it, and you can just flange it, or you can say this modified Yamane technique kind of thing, because I didn't want it to explant this IOL because the IOL was very much of the correct biometric calculation. So it had just slipped away. There was no back support because of trauma. So again here you can see I'm using a ILM forceps in a fashion where I entered using the ILM forceps in a Z-type fashion, catch hold of that tip of that IOL and externalize it. And once you externalize it, flange it properly and put it back into the track. So this was how it was shown after surgery. This is post-op day 1. You can see the scar because of the trauma he had, and the patient is really doing well. So thank you very much for the patient listening. Thank you.
A very nice effort in the first 2 cases actually. It is really tough in case of vitrectomized eyes doing all that maneuvers inside, because the eye will also be collapsing in these cases. It is not like anti-segment person doing a scleral SFIL where the vitreous is found, vitreous is there and it's very supportive to the globe. So in this it's very, very tough in vitrectomized eyes, and he has done very nicely. But my question is that you could have adapted the last technique in the first 2 cases as well.
No, that's what, sir. The
Yeah,
first one which I showed, the chariot stake tunnel which I did was a pretty old
I know.
thing.
Previous
so
cases.
Yeah,
yes.
it was very old video.
Yes.
Even the video quality
But
also you can see.
Yeah. Only suggestion I have is you have not made a scleral flap in the last case.
Sir?
You have not made a scleral flap in the last case. Actually, we always should do, because I have seen patients coming with only for the symptomatic, the lot of pain because of this tip from the other surgeons, and I had to use a scleral flap to make them comfortable.
That
That is very
I
much
definitely
required
agree
in
with that
scleral
point,
SF.
sir.
Yes.
So here what I showed was where it goes back into the track. See,
I
I
know
make
that.
a Z entry kind of thing,
Yes,
and
yes.
that bulb will be lying in the scleral track. But in case the bulb is very irregular, at the same point of time, you can
Erodes.
always make a flap also at that point of time.
It erodes and it will
Yeah,
come
correct.
transconjunctivally, and it will be
So-
very symptomatic for the patient. Anyhow, we are on time for this session, and we
Thank
are
you, sir.
closing
Thank
on
you very
time.
much.
Thank you all for your patient listening, and I thank all my co-chair and all the discussants. And thank you very